So we are on live now, sir. You can start.
I'll start. Okay. Good afternoon, doctors. Welcome to this webinar on the role of Oseltamivir flu management. This program is brought to you by Hetero Healthcare, an innovative pharmaceutical company. Hetero Healthcare, the journey began in 1993. We have 30 years of excellence and 36 state-of-art manufacturing facilities, 300 plus products in portfolio, and presence in 126 plus countries. Hetero Healthcare has about 21,000 employees globally and is the largest closely held pharmaceutical company in India. Hetero Healthcare features amongst the largest manufacturers of ARV, APIs, and FDFs in the world, and has Asia's largest API manufacturing facility at SEZ Complex, Visakhapatnam, Andhra Pradesh. Hetero Healthcare is 360-degree solution provider, striving to fulfill unmet healthcare needs, reaching to customers across India with wide product range encompassing multiple specialties. Hetero Healthcare pioneers in quality and innovation and has the distinction of bringing 4 biosimilar products to market within 5 years of initiation. They are darbepoetin alpha, rituximab, bevacizumab, and adalimumab. During COVID-19 pandemic era, Hetero Healthcare, the pioneers in antivirals, offered Oseltamivir, Favipiravir, and Remdesivir to the patients, because of which, in August 2020, Hetero Healthcare received an award of Pharma Excellence for COVID drugs. Today's webinar role of Oseltamivir in flu management, we have Dr. Pramod Zog as our moderator, with Dr. Sanjay Nathu and Dr. Anil as our speakers. Welcome Dr. Zog, welcome Dr. Nathu, and welcome Dr. Anil. Dr. Pramod Zog sir is Professor of Pediatrics, D.Y. Patil Medical College, Pune, President IIP 2016, Steering Committee Member GAVI so 2016 to 19, Chairman Mini Recipe Module IIP, author of book Cophology. Dr. Sanjay Nathu sir is MD DNB Pediatrics, MN AMS FACEE, currently Professor and Head of the Department Pediatrics from March 22 till date at Srimati Kashibai Navodaya Medical College at General Hospital, Pune. Consultant Pediatrician at Shaswat Hospital, Kothurud, Pune. Area of interest include pediatric pulmonology, pediatric infectious disease, pediatric emergency medicine. Sir is President IIP Pune Branch 2021 and member of Pediatric COVID Task Force, Pune Division. Welcome, Dr. Nathu. Dr. Anil is MBBS MD Fellowship in Pediatric Critical Care, DAA Diploma in Allergy and Asthma. Sir is Lead Consultant Pediatrics and Pediatric Critical Care, Spurs Hospital, Bengaluru. Welcome, Dr. Anil. With this brief introduction, I stop sharing and I hand over the session to Dr. Pramod Zog. Over to you, sir.
Okay. Are you able to see the slides?
Yes, sir. Yes, sir. Clearly.
Okay, thank you. Okay. Okay. So, good afternoon, friends. Today we are going to discuss about the use of Oseltamivir in flu management, and I am very happy to have Dr. Anil from Bangalore and Dr. Sanjay Nathu from Pune for this particular discussion. As you can see, the influenza virus usually has a typical nomenclature, and I have tried to fit in my own name in the fashion of the flu virus so that you understand. So, any flu virus has some origin. For example, the 2009 pandemic influenza virus was also, given a particular name. This is important because every year the strain of the flu virus changes, and all over the world these strains will be known by their particular nomenclature, which includes the place of origin, the year of origin, and so on and so forth. Okay. So, one should understand that influenza primarily is a disease which is seen during monsoon. However, in India, it is seen all around the year. And in certain parts of our country, like Kashmir and Kanyakumari, it is seen in the latter part of the year, like in November or December. The incidence of influenza is very much related to the season, and there is definitely a seasonal variation. So in US, many times these cases are seen at this particular moment, like in November and December, and people there are really, really worried. And as we all know that the age of people there, the older age people are also huge in number. They always want to have this flu vaccine so that they do not have problems related to influenza. In monsoon, we also have other illnesses, like, for example, respiratory syncytial virus. We also have arthropod-borne diseases like dengue. Of course, malaria is not seen to a great extent now in India, but then we should be aware that in monsoon, it's very important that we are alert about the differential diagnosis of different diseases which affect children. Okay. And these days, the viral infections in the practice may not be very simple. We all know that some of these viral infections, they appear very benign, in the initial 3 4 days, but on day 5 6 or 7, they go and land up in what is called as cytokine storm. This we had experienced during COVID times. So it is always prudent that you observe or ask the parents to report some of these important danger signs, when a child is brought for plain simple viral infection, because in the initial phases it may appear very simple, but later on it may take a different turn. And after COVID, these various viruses like respiratory syncytial virus, hand foot mouth disease, adenovirus, and measles, in areas where measles immunization was on the lower side, they started showing themselves up because during COVID there was immune debt. So children did not have the immunity against some of these viruses, and that's why the incidence of some of these viruses, which were, so to say, hidden during COVID times, they started surfacing up. So it's very important that we are aware of all these facts related to viral infections in children. And in the post-COVID period, we are witnessing that even the older children are getting affected by these various viruses. Recently, we had a case which was a 3-year-old boy with fever, cough, and cold, and progressive breathlessness. The child was tachypneic and had hypoxia, and the X-ray of the chest showed acute respiratory distress syndrome. The child was not in a good shape, and that's why he was admitted in the intensive care unit. He was ventilated. He was given Oseltamivir along with supportive therapy. The throat swab showed H3N2 positivity. This child was ventilated for 3 days and then he improved. After he was discharged, we had a discussion in our unit, and we were thinking as to whether a previously healthy child presenting with cough, cold, and fever who shows rapid progression, one should be very, very careful, and whether we can avoid this particular progression. That is what should always be at the back of our mind. So whenever a child has, a presentation akin to influenza and which starts with cough, cold, and fever, and usually you suspect influenza in a flu season, whether oseltamivir should be given upfront to play safe. We will all discuss these particular issues during our discussion, and let us see what are the points which are likely to be confusing for a practitioner. For example, when a child comes with respiratory infection, we have to first find out whether it is bacterial or viral. We all know that bacterial infections are usually localized. Either, say, respiratory infections will localize to the tonsils, or a child might have only pneumonia. But usually both these conditions do not coexist. Similarly, a bacterium like Shigella, it will produce only bloody diarrhea. It won't at the same time infect other systems. But viruses usually can have generalized infection, and then a child who has respiratory involvement can also have involvement of the GI tract, also have rash on the body, and so on and so forth. So it's better that we are aware of the differentiating points between bacterial or viral. It's also important that a child coming for cold and cough, is evaluated for allergic disorders, because many children, those who do not have fever but have allergic symptoms in addition to cough and cold, like sneezing or itching of the nose or itching of the eye or watering of the nose, one should be aware that not all that is cold is, infections. There could be children who have viral infections and allergy both. So one should be clear about the differentiation. And in case if one suspects that this is a viral infection, which is the virus, whether it is rhinovirus, adenovirus, influenza, parainfluenza. If it is influenza, what is the type of influenza, whether it is H1N1 or H3N2, and then whether one should start oseltamivir upfront. All of us are aware that during monsoon, all those influenza like illnesses are seen to a great extent, though influenza A is the father of all those influenza-like illnesses because it comes with systemic involvement, like severe headache. A child can have severe muscle pain, and he may have a lot of weakness. And in fact, many parents have to, lift the child who is even an older child and bring to the OPD. So severe headache, muscle pain, weakness, all these are seen in influenza. Other viruses like rhinovirus and all, which are usually localized to the nose, they do not produce such a picture which shows systemic involvement. And during last few years, the morbidity and mortality related to influenza in India is alarmingly increasing. As I was trying to tell you, influenza A is the one which is also responsible for frequent epidemics. These epidemics are because of the minor antigenic variation. And on the outer side of the virus, there are certain glycoproteins like H and N. I will be telling you about them. So if there are some changes in the amino acids of these, viruses on the outer side, then every year, this type of the strain changes to some extent, not a great change. So, it's a very, very minor drift. So it's called a antigenic drift. But once in a while, what happens is that viruses from the birds, viruses from the human beings, they mix up in some third, party, like a pig, for example. And then in the pig, there is origin of a novel influenza virus. This is what happened in 2009. And that's why pig, we call it as swine. So it was swine flu, which occurred in 2009, and that was a major antigenic shift. So that, the community did not have any immunity against this novel influenza virus, and that's why it spread like a pandemic. As opposed to this, influenza B virus usually infects only the human beings and causes local epidemics. So it is important that we are aware that this is an RNA virus. Viruses are either RNA or DNA, and they require both for their survival. So as simply with RNA, this virus cannot survive. So to get all those copies of its own reproduced, it has to take the help of the DNA, and that's why when it enters into the respiratory epithelial cell, it dictates the DNA of the human respiratory epithelial cell to produce similar copies. Okay, and that is something which it does with the help of these two enzymes, HA and Na. Hemagglutinin HA is the molecular key with the help of which this virus RNA, gets attached to the respiratory cell, and then the RNA enters into the respiratory epithelial cell. Inside the cell, it multiplies, and all those different virions, they are separated from each other by this neuraminidase, which is a molecular scissors. And these virions are able to get out of the respiratory epithelial cells to infect the other respiratory epithelial cells. And oseltamivir is the molecule which blocks this particular, release of these virions. And that's why it's very important that to spread the viral virions going outside the respiratory epithelial cells and getting infected other cells, these neuraminidase inhibitors are given on time. Okay, as I was trying to tell you, this pandemic is something which has taken a great toll in the last century. So in 1918 and 19, there was Spanish flu. Then there was 1957, 1967, and then 2009. Four major global pandemics which started in some part of the world and then they spread all over the world. So, Dr. Sanjay, I would like you to tell our listeners about your impression about the epidemiology of influenza and the various strains of influenza which are affecting the pediatric population these days.
Yes, sure, sir. So, first of all, good evening to all the delegates listening. And yes, we have had a lot of influenza cases in the last 2 to 3 months, and we have been doing the typing of these patients whenever possible. And what we have seen this year is majority of the patients which we were seeing belong to influenza A, and the type was H3N2. So most of our patients were coming H3N2 positive. A few of them did come positive for H1N1, that is a pandemic strain, but the number was quite less. And just an occasional patient who was a little older usually would be positive for the influenza B type. But most of the patients which we got were H3N2 as far as the influenza was concerned.
Okay. Dr. Anil, do you have any additional experience about the epidemiology?
No, sir. I think our experience also has been very similar. We have been getting more of H3N2 this year, and yes, of course, H1N1 also we did get. So I'll just tell about this PDM09. So, sir also already gave us the KYC details of these viruses, and when we are looking at these viruses, the subtypes will have H and N, that is the hemoglobin and neuraminidase. So based on these antigens present, so they are subtyped into various numbers like 1, 2, 3, it is given. So whenever there is a slow change in these antigens, so there will be change like H1 may become H3. But whenever there is a sudden shift of antigens, it will be a sudden shift, and that is when a new virus or a pandemic virus erupts, which will spread across the globe. So the H1N1 is the pandemic virus type which we got in 2009, which is still around. So here also we have been getting more of H3N2 and H1N1 only.
Thank you. So this flu virus usually spreads by the respiratory route by droplets, and from the person who is infected, it goes and lodges itself, onto the mouth and the nose of the person in front whenever the affected person coughs or sneezes or talks. And these droplets usually are the ones which are, responsible for the transmission. It's a virus which transmits very rapidly, and the R naught, also known as R0, that is the transmissibility, is very fast in case of flu, as in case of RSV and also like COVID. And Dr. Anil, would you like to tell our listeners about the clinical scenarios with which influenza presents?
Yes, sir. Influenza, it's more like any other acute febrile viral illness which we see in our OPD. Majority of the cases are the simple viral illnesses which walk into our OPD, which may come with fever, cold, cough, malaise, body pain, and these kind of upper respiratory viral kind of a scenario. These are the mild varieties. But we do see the moderate ones and the severe ones also. So it may kind of progress. Usually the presentation what we get, it's much more severe than the common cold. So these children may present with very high grade fever, headache, body pain, sore throat, inability to eat, and all that. And if it progresses, they progress on to develop some respiratory issues and other complications also. So in simple terms, if you have to put, flu is a very, very bad common cold kind of a situation, but the systemic symptoms will be much more than the common cold.
Sure. We all should remember that it's very difficult to differentiate one respiratory virus from the other one. Uh, Finer points which would differentiate these viruses from each other. Like, for example, we know that during COVID times, we all, we're discussing about this loss of smell and the loss of taste. Okay. And as Dr. Anil just said, in influenza, we have headache, weakness, and muscle pain, which are predominant. Most of these viruses, when they progress, they may land up in certain, particularly some viruses which may take a serious turn, like H1N1 or COVID-19. Sometimes, they, turn into a very serious clinical picture. So, Dr. Vijay, particular seriousness has to be assessed quite early. That is because parents, in case if they are aware, and even the pediatricians, if they are aware of these warning signs, then at least we can start oseltamivir on time and everything will go well. So, will you just like to tell us about the emergency warning signs of the flu illness?
Sure. So as Dr. Anil has already pointed out, most of our patients tend to be simple cough, cold, fever, body ache, malaise, that sort of situation. But yes, we need to be aware of the warning signs because the parents need to be told what they need to watch for when they are going to stay with the child at home. And we also need to be aware regarding these signs when the patient is called for follow-up. So we would preferably like to call patients for follow-up after 48 and 72 hours roughly to see if these warning signs or red flags are there. So what do we usually look for? We would be worried if the child is having a fast breathing or he has increased work of breathing or he has some cyanosis, he's a little too ill, not drinking adequate fluids, not eating well, not interactive or lethargic, like he's drowsy all the times. So we would expect in a viral fever, the child is active in the interfebrile period. But if the child tends to be like sleeping all the time, even during the breaks of fever, That is something we should be aware of. Unusually, we would get rashes sometimes, but not a very common picture with influenza. Similarly, in adults as well, difficulty in breathing or chest pain or dizziness or would be something which would be alarming. And the parent should also be aware of these things, or the patient should also be aware, as well as us as doctors should be looking at these things when we follow up these patients.
Sure. And in the latter part of our discussion, we will be discussing some complications so that we'll know as to what are the indicators of complications. And these complications are roughly related to the alphabet A, as I would put them as ARI, which includes pneumonia, or ARDS, acute otitis media, absenteeism from the school, and also, loss of income, that is amdani for the parents, and then antibiotic abuse. Why these viral infections get complicated with problems like pneumonia is because these viruses, they damage the epithelium, and this epithelial damage sets a stage for bacteria like pneumococcus or staphylococcus to produce secondary bacterial infections. And there are various figures ranging from 10% to 25%. That means the percentage of secondary infections in children with influenza. One should be aware of this because two vaccines, one of them is of course pneumococcal conjugate vaccine, and other is the influenza vaccine. They would definitely be of great help in reducing the mortality related to pneumonias in children. Of course, as it's very difficult to differentiate the viral from the respiratory, unless you get very, very clear-cut clues like follicular tonsillitis or tender cervical node. One is very much confused about whether one should give antibiotics or no. And moreover, our colleagues practicing at the periphery where patients may not be able to come back, many times they'll end up prescribing antibiotics, and many a times it leads to antibiotic abuse. So it's very important that we are aware of all these facts related to influenza. Dr. Anil, would you like to tell us about the categorization of influenza into categories A, B, and C so that we can then discuss the therapy related to these categories?
Yes, sir. Whenever the child comes to us, we still don't know if it is influenza, some other virus causing this. So we make a syndromic diagnosis of what we call as an ILI or an influenza-like illness. So here we would categorize them into category A, B, and C. To keep it very simple, category A is our OPD, regular OPD patient that we would see. Child who would come with fever, headache, body pain, little bit of malaise, but his child still doesn't have any of the red flag signs that sir told just now. Child is still active with a good oral intake. They have a fever, body pain, headache, malaise, so little bit of sore throat. All these things are there. These are the regular category A kind of patients. Category B are the moderately sick kind of patients. Again, in category B, we would classify them into 1 and 2. So again, category B is much more sicker than compared to category A. Here, little more sicker. The fever spikes are much higher, severe myalgia, body pain, or inability to drink. All these things are there. And again, in this category, we should not forget the high risk patients who are categorized. They may be still category A when it comes to symptomatology, but they'll have other high risk factors like in urban areas. We should not be forgetting the obesity which is there. They may be immunocompromised. They may be on steroids for any other reasons, or they may be on chemotherapy for other reasons. All these things which will come into high risk zone. So all these patients by default they'll come into category B, who are high risk or they're having severe symptoms. And of course, category C is the much more sicker patients. We would actually admit and put them either in a high dependency unit or in the PICU. So these are the patients who will have red flag signs, who are inability to eat, they're having tachypnea, respiratory problems, and neurological problems, or much more complicated flus. They will all come into category C.
Okay, we will just have a quick look at this molecule called oseltamivir. As I told you, it's a neuraminidase inhibitor, and it blocks the viral neuraminidase enzyme, which is critical in releasing the virions from the infected host cells. And basically, the prodrug, which is converted into the active form in the liver. And this was the first oral neuraminidase inhibitor, and it is approved in more than 100 countries. And the CDC and the American Academy of Pediatrics has approved this particular molecule. We have just seen the categories for treatment and the recommendations for the use of oseltamivir. So, Dr. Sanjay, will you just like to give the summary of the treatment guidelines?
Yes, sir. So category A, as we discussed, is the typical OPD patient, which we see, and that this patient just requires supportive treatment, home isolation, definitely rest, adequate fluids and hydration, and only paracetamol for fever or that are required. Of course, you need to follow up this patient after 48 hours, 72 hours, but treatment-wise, he would be well only with these things. Category B, as Dr. Anil has already pointed out, is the one with a more severe presentation or those with a little coexisting problems in them. And in such patients, it is preferable to start antivirals as soon as possible, preferably within 48 hours. As far as the testing of these patients is concerned, it is an optional thing. It is can be done if it is easily available and affordable to the patient, but that is not mandatory. And you need to start the antiviral as soon as possible. Whereas category C obviously is the one who is admitted in the PICU or the high dependency. So this patient definitely deserves the antiviral as soon as possible, along with aggressive management of the other complications, if any. So category A, no antiviral. Category B and C, definitely we need to start antiviral as early as possible.
Thank you. And this oseltamivir has a particular dosage schedule. So in adults, usually we give 75 milligram capsule twice a day for therapy. And for prophylaxis, we give 75 milligram capsule once in a day. And in children, depending on the weight, from 15 kg up to 40 kg, we give the dosages in milligrams per day for therapy in two divided doses and for chemoprophylaxis in a single dose. But chemoprophylaxis has to be given for 10 days. In the infants, the dose is 3 milligrams per kg twice daily. Now, Dr. Anil, I would just like you to tell our listeners as to how early initiation of oseltamivir influence the clinical progression and whether one can give oseltamivir even for a child who presents to us little late.
Yes, sir. Like you had just now explained us regarding how it works. So it spreads the diffusion or spread of these virions from one cell to the other cell. It stops the multiplication and the release of these virions. So theoretically, by starting this oseltamivir early, we are going to stop the spread of these viruses from affecting the other organs or spread in the individual itself. So multiple studies have shown us that by starting oseltamivir much early, that is within 48 hours of onset of illness, we're able to reduce the duration of this illness by 1 to 2 days. There are multiple studies, and even WHO also says that this is what happens. So somebody who has gone through this kind of a very bad flu, which presents with severe debilitating high-grade fever, body pains, tiredness, and all this, they'll vouch for it that even that reduction of 1 to 2 days is very, very valuable. And more so, what it does is it prevents the spread of the viruses and also the complications and other organ system involvement. And also, it is kind of protective for the other people in and around the index patient. So, early starting of oseltamivir is very, very important. And there are multiple studies which have proven this time and again.
This particular fact has been supported by quite a few clinical trials, and it has been seen that in patients with influenza, oseltamivir treatment reduces the antibiotic use by 26.7%, also reduces the lower respiratory tract complications and also hospitalization. And this is true even for the adults. And that is why there has been a guideline even by WHO, which states that empiric treatment is strongly recommended. Treatment should be started as soon as possible. Laboratory confirmation of influenza infection is not necessary for initiation of therapy. And the need for H1N1 exclude the diagnosis in all the patients. We will just have a look at some of the cases. So, we'll have a better idea about the management approach. So, this is a child who came to us for fever for 3 days, cold and cough. This child was on metered dose inhaler since 4 months, was well controlled on this therapy. And for this cold and cough, he received symptomatic therapy. But after that, he remained afebrile for a day and again came back after 3 days with fever. And in between, of course, this particular child was quite active. So this is a very common scenario in the practice. We get children with recurrent viral upper respiratory infections. As I said, they have become quite frequent. And these children, they come to us even at shorter intervals, and the parents are worried. And many of them, they may pressurize you to start with antibiotics. So, Dr. Sanjay, I would like you to tell as to how would you counsel these parents related to, the management or the approach or the administration of antibiotics.
Right, sir. So I'm sure all of us pediatricians have seen a lot of such kind of patients in the last 2 to 3 months who have been coming up with like one episode followed by another. The good thing we have to find out is whether they have been almost normal in between the two episodes. That is very important. Then certain things like going to a daycare or a playgroup exposes these children to more and more number of viruses, and this causes them to get repeated infections. So what we have to speak with the parents or discuss with the parents is how is the patient, how is the child in between the episodes of fever, how is his growth and intake, and for that we can take help of the growth chart and see and show the parents that the child is growing well, the weight is being gained regularly or not, and that would reassure the parents a lot. We should also like make the parents aware that most of these preschoolers are going to have 6 to 8 upper respiratory infections in an year, and hence this is going to be a norm for the first 3 4 years or 5 years of life, and they need not panic as long as the child is otherwise growing well, eating well. So the most important thing is that we need to spend time with the parents, discuss with them their concerns, and try to show them that the child is otherwise well and the infections are just viral infections, which is going to help the child in the future to build up its immunity.
Dr. Anil, do you have any additional points which you could add in the counseling?
No, sir. I think this is the exact scenario which I think all of us pediatricians will face, and spending those additional 2 3 minutes and reassuring, finding out. We sometimes we directly ask them the question: what is the thing which is causing anxiety to you? What is the thing that is bothering you? Is it that the child is not well, or you? Some of them feel that there is something majorly going wrong. So by using the growth charts, plotting them in front of them, and telling them, reassuring them things are all right, will go a long way.
Right, right. And I remember you telling us that consider cough and cold as the additional member of the family. If you tell them, then they're reassured that, they are, dealing with something which is, quite common in these children. That's great. So it's better that our colleagues know as to how to identify some of these viral and bacterial, organisms. For example, as I was telling you earlier, rhinovirus is responsible for common cold where the child doesn't have much of fever, or maybe the fever is very mild, but the child is otherwise quite playful and there is no exhaustion. While viruses like flu, they will produce a different kind of a picture, which we already discussed. Viruses like adenovirus may come with pharyngoconjunctival fever or diarrhea or mesenteric lymphadenitis or hemorrhagic cystitis. While in children under the age of 2, particularly under the age of 1, we get RSV producing bronchiolitis. Bacteria like group A beta hemolytic streptococcus will produce fever with follicular tonsillitis and tender cervical nodes. Pneumococci will lead to pneumonia, which may present as fever, grunting, tachypnea. And staphylococci will always show rapid progression. The child will be much more toxic, while mycoplasma will affect relatively older children who will present with predominant symptom of cough. So, Dr. Anil, this is a child, 4-year-old, and he came for fever and fever of high grade and not settling with routine therapy. And on admission, he had tachypnea and needed oxygen support. His total count was 1620. The platelet count was 132,000. The liver functions were mildly deranged, and the nasopharyngeal aspirate was positive for H3N2. So we diagnosed it as a case of influenza with low WBC count and low platelet count. So I would just like you to tell our colleagues as to when such a child comes to the OPD, what is the best approach?
Yes, sir. This child already is into day 5 of this typical respiratory kind of illness, and already child has developed few complications like category C. Directly will fall into category C kind of symptoms because child is tachypneic, requiring oxygen, and on X-ray already infiltrates have formed. So this is a child directly we would end up admitting in our hospitals probably before we get all these blood reports. Probably it will take a couple of hours at least to get the blood reports and all that. So we admit them, start doing the necessary supportive treatment for this child. we place IV cannula, take the blood cultures, and probably for a sick child, we would go ahead and start the antibiotics after taking a blood culture. And of course, with the background of this influenza illness that is going on, definitely empirical therapy of oseltamivir is very much indicated in such a patient. And probably once we get our labs back after a few hours, we see that there is leukopenia, total counts of 1,600 only, and platelets also are on the lower side. And kind of tells us this could be viral. And but still, till we get the swab positive, we would continue this child on both the antibiotic and antiviral oseltamivir also. And I think we should highlight that the transaminases SGOT and SGPT are raised in this case. So whenever this epidemic of flu is going on, we should not forget our old friends for an arthropod-borne disease like a dengue, which can still be around. So this is respiratory, but this totally transmission is totally different. But we should remember that these infections can coexist. Like in the community, when the transmission is very high, we can get a co-infection also. So in such a situation, it is worthwhile to get a dengue rapid test or ELISA if it's available, to get the ELISA done as soon as possible. And probably once we get the swab, probably after 24 hours or so, then we can do the de-escalation of antibiotics or stopping the antibiotic depending on the clinical progress.
Right. So it's very important that we monitor such children. And even though primarily it appears respiratory, this monitoring may be of great value in diagnosing some other illnesses or progression of influenza itself. Dr. Sanjay, there are some other cases which came to us with fever which was not settling and nasopharyngeal aspirate showing H3N2. And I would just like you to tell about the factors on which the clinical response to oseltamivir depend. Already we have discussed it in part. You can just repeat what we said.
Right. So the first and foremost is it has to be influenza. Only then the oseltamivir is going to work. The other thing is how early do you start oseltamivir? And it has been discussed previously in this webinar today as well that earlier we start the better. And starting oseltamivir early, preferably within 48 hours, gives the best response and prevents the worsening of the disease, prevents most of the times the complications. And the patient usually starts recovering within a day or two. So the earliest, the best thing which we should do in such patient is start oseltamivir early. Having said that, that doesn't mean that if the patient is referred to you on day 4 or 5 and has a swab which is showing a H3N2, for example, you should not start oseltamivir because it is day 4 or 5. That is not right. You should start it even when the first time you see the patient, especially if the diagnosis is confirmed, then there's no point waiting. You should start oseltamivir even later.
Oh, thank you. So, of course, this case deceived us because, this child had very high WBC count and high CRP with continuous high fever, and it turned out to be positive for the adenovirus. This was a girl, 5-year-old, with high fever for 5 days, cough and cold for 5 days. The child was sick looking. She had mild wheezing, but there were no crepitations. So in such children, Dr. Anil, what is your policy as to how to proceed, whether we should put them on antibiotics pending the laboratory reports, or how would you approach such children?
So this child already is into day 5 of illness, and from the description, it looks like she's quite sick, has developed some respiratory symptoms also. In such a situation, when someone is sick for 5 days, we don't hold back on the antibiotic. I think we would go ahead and start this child on an antibiotic also with the empirical antiviral. And then probably we investigate, monitor the child, and then we can take a call as to what needs to be done. So if such a child comes in our practice, we would go ahead and start this child on IV antibiotic, probably coamoxiclav after taking blood culture, start on oseltamivir, and then we do the further workup like the X-ray, blood tests and all that, and then we'll take a call.
Right. So accordingly, this child was put on amoxiclav. The WBC count was 2800, the CRP was 34, and this child was also put on oseltamivir. But the nasopharyngeal swab turned out to be positive for rhinovirus. So with this, I will just like you to tell our listeners about these tests which are done for the diagnosis of a particular type of virus, and how good are they in diagnosing or ruling out illnesses like influenza. So, what is your opinion?
Yes, sir. I think the recent generation of PCRs are quite sensitive and quite specific also. Yeah, in fact, the sensitivity is more than 90%, reaching to almost 95% in a well-collected swab. So whenever we are doing a swab, it can be just a flu swab, checking only for the influenza A and influenza B, or it may be a panel also, which checks for multiple other respiratory viruses. So depending on availability, the affordability, what is available, we do order these tests. A well-collected swab, that is, it should be taken from well deep in the nasopharynx, and sometimes even the throat secretions can be sent across. So the sensitivity is almost 95%. Why, if they are not taken very well, the sensitivity will drop down to 60%. So before sending the swab, we should have a clinical diagnosis in mind, like if this is fitting into an influenza-like illness kind of a scenario, and then we interpret the test. And in such a scenario, we got a rhinovirus being positive. We know that clinically rhinovirus is just a localized virus, causes lots of discomfort in the nose, lots of rhinorrhea, and probably a mild feverish kind of a scenario, which is self-limiting in a couple of days. So here the rhinovirus is not expecting someone to be sick even on day 5. So this could still be a influenza. In such a situation, I think it's worthwhile to continue with the oseltamivir in such this patient.
Very good. Now, Dr. Sanjay, this was a 7-year-old daughter of IT sector parents, came with high fever for 3 days, throat irritation. The girl had her examination 2 days later. The throat showed mild congestion. The child was put only on paracetamol, and flu and adenovirus were around. So the parents were not very happy with the prescription of paracetamol alone, and that's why the pediatrician had a dilemma as to whether he should go ahead with investigations, do a throat swab, or put the child on empiric oseltamivir. I'm sure such patients are not uncommon in the OPD. So how do you tackle, such situations?
Yes, sir. So these, we all are aware, these IT sector parents are a very anxious lot, and they have already Googled things and they come when they come to us. So we need to, again, as Dr. Anil has mentioned, we need to spend time with them, because if you look at the patient's history, there has been fever for 3 days and some throat irritation. But other than that, not any severe findings have been mentioned. So this looks like a very mild type of influenza-like illness. I would probably categorize in type A or category A. And this would just require a supportive treatment with paracetamol, which has rightly been prescribed, a hydration which has to be maintained well, some isolation obviously, and a follow-up. Just the pressure of exam should not be the reason to start oseltamivir in this particular case, because that would be a little going over the board. So such patient would preferably be just given supportive treatment, and of course the follow-up would be the most important thing. I would not be very keen on doing any investigations so early, because there are no localizing signs as such at this stage. So, and the symptomatology is also quite mild. So I would just wait and ask the patient to follow up and then decide if I need to do anything more.
Right. So the categorization will definitely come to our help when we are facing such educated parents, so that we can just tell them that these are the categories and your daughter fits in category A. So there is no reason for, doing all the investigations and putting the child on any particular medications. And then this is a child, Dr. Anil, a 3-year-old boy, came for cough for a week, high fever for 3 days, crepitations. The child was put on co-amoxiclav and admitted for persistent fever. He was put on IV amoxiclav, and the WBC count, the CRP were almost normal, and throat swab showed influenza A, and that's why oseltamivir was also added. And then, of course, our colleague had a problem. Mentally, he was not able to decide whether to continue both or whether to discontinue the antibiotic and then continue only with oseltamivir. So, in such a situation, how would you, think about the further approach?
Yes, sir. This is one situation. Getting a flu positive on the swab gives us a lot of confidence to go ahead and stop the antibiotic which you have started. So, as a syndromic diagnosis, we know there is a backdrop of flu that is happening, epidemic that is happening, and the CRP is negative, and the flu has been detected on the swab. So, this is where our stewardship comes in: antimicrobial stewardship, and even the diagnostic stewardship. So we should act on the diagnosis that we have asked for. So the swab is showing us influenza positive, so we should believe it. Just now we discussed the sensitivity of this swab, since it is a very good sensitivity and this can explain the syndrome, clinical syndrome in hand, I think we should take this as a causative organism and stop the antibiotic. But we should be at the same time carefully observing how the patient is improving. Because after oseltamivir, we do see a very good improvement within the first 48 hours of starting the oseltamivir therapy.
Right. So likewise, we have come across quite a few cases wherein we witnessed some complications. And one of these, children was a child 1 year old with fever, cough, cold, and status epilepticus. And the nasopharyngeal swab showed H3N2. The counts were normal. And the MRI showed non-specific encephalitis changes. And CSF was normal. And it was diagnosed as a case of influenza encephalitis. So, in the intensive care settings, Dr. Anil, what are the various neurological problems which you have witnessed in relation to influenza?
Yes, sir. This flu season, we had more number of cases with influenza getting admitted for respiratory and non-respiratory causes also. When we are talking about the non-respiratory causes, CNS causes were the most in number. We saw that there was increase in the number of febrile seizure admissions to the ICU overnight. And also we did see that lots of children, especially little older children, because of the high fever, they came in very delirious, though they had febrile delirium also. And febrile status epilepticus, there were quite a few number of children who came in, and few of them turned out to be positive for flu. And also, one case turned out to be acute necrotizing encephalitis. In general, they do have a very bad prognosis because of the CNS affection. We do see that the basal ganglia and the deep nuclei get involved. What we see, JE kind of a presentation. They're deeply comatose and the seizures don't stop at all. And there are areas of necrosis also which develop within the deep nuclei. So luckily for us, our patient had improved. And as expected, the CSF will be not showing a cellular response because, like Sir had described, this is more of a cytokine storm kind of an insult which happens to the CNS as secondary to the viral insult which happens. There is a secondary cytokine storm which is generated and the CNS takes a hit. And of course, a lot of cases of aseptic meningitis also is seen.
Right. So, Dr. Sanjay, have you seen any other child with complicated influenza?
So, as Dr. Anil has mentioned, so febrile seizure, febrile status is what we commonly saw, and just one odd case of necrotizing encephalitis was also seen. But otherwise, no, those are the common presentations which we saw.
Right. And some of our colleagues have witnessed myocarditis. And of course, some of these problems like myositis are seen more with influenza B in boys in the age group of 6 to 9 years with bilateral gastrocnemius and soleus involvement. And these children come with severe bilateral calf muscle pain, inability to walk. And of course, in the olden days, we used to see Rye syndrome, which was related to the use of salicylates, particularly in children with influenza B. And these children had a picture akin to liver cell failure. There are certain quick questions for both of you. So, Dr. Sanjay, uh, an elder sibling of an 8-month-old child is admitted with influenza A for LRTI, and this 8-month-old child develops fever last evening and comes to you today morning, and the mother says that his elder brother is admitted with influenza A for LRTI. So, what do I do with this younger one? Shall I put this child on oseltamivir?
Yes, in this situation, because the elder sibling is already positive for influenza A, the 8-month child now, if you look at the categorization, goes into category B, and because of his age per se, and hence I would be very keen definitely to start him on oseltamivir as early as possible, so that he doesn't progress and improves very fast.
Dr. Anil, if a child doesn't accept oral medicines, is there any other alternative?
No, sir. Currently, I don't think so. We have any alternative. IV baloxavir and other antivirals active against influenza is not available in India. But generally, in our practice, oseltamivir has been very well tolerated. So sometimes they may present with little nausea, but even that improves with usage. Like after 1 or 2 days, that nausea also improves. So somehow we need to make sure we give it orally.
Okay. And then Sanjay, how this child, what is your giving prophylaxis to some of the household contacts?
Right. So, in a routine household contact, I would not be very keen to start chemoprophylaxis, for example, for an healthy adult. But for someone who is of an elderly age group, say more than 60 or 65 years of age, or someone who has a predisposing factor, for example, a diabetic or someone with a chronic renal conditions, yeah, then yes, in those situations, I would definitely think of starting chemoprophylaxis to all those who have a high risk condition going on.
Right. It's very important because, as all of us know, that influenza is a disease which spreads from children to the adults. And that's why in a family, many times, we have a diabetic father or a pregnant mother or, grandparents who have asthma, and they come under the high risk category. So, this child is most likely to spread the illness to these, people in the family. And that's why they are the ones who could be rather given the chemoprophylaxis, as we discussed earlier. And then, Dr. Anil, in case if we are facing a child with para-influenza, whether oseltamivir would work in these patients?
No, sir. In para-influenza, oseltamivir has got no role. Usually, para-influenza viruses are what we get in very small babies, like in our infants, and the presentation is an acute croup kind of kind of presentation. They present to us with a stridor, and they improve also very well within a day or two. So here, oseltamivir is not indicated.
Right. So we have discussed almost all the important points in connection with influenza and oseltamivir. And what we have realized that it's a virus which has a very abrupt onset. The transmissibility is also very high, and the people in contact they get quickly affected. And the progression to complications is also quite rapid. And even some children we see develop ARDS. And that's why we have to be very fast in our decisions, like starting oseltamivir. We also need to be very much particular about preventive modalities like using the sanitizers, the mask, and also social distancing. We also must follow cough etiquettes. We should try to cough in the elbow so that there is no direct contact of the secretions with the hand, and inadvertently we do not touch the objects with the hand and prevent the spread of the virus from hand to others. And also we should follow certain rules, which I put them as Hasta Pancha Sutri, 5 sutras related to the hand in the form of hand washing. Particularly after examination of each and every child, one should wash the hands. Also, avoid handshakes, use handkerchiefs, also keep the patients and others at a hand's distance, and avoid hand touching. And of course, that will be of great help in prevention of the transmission. It is important that all of us, including our staff members, get vaccinated against flu, because it's one of the vaccines which is available for this viral illness. The efficacy is in the range of 60 to 70%, depending on the matching of the strain in the vaccine with the virus circulating in the atmosphere. But with the common viruses like H1N1 and H3N2, which are usually covered in the vaccine, the protection offered is to a good extent. And that's why, in addition to saying happy birthday to you, one must always say happy birthday to flu, so that you remember that you have to take annual shot of influenza. We are not going to discuss much about the vaccine today, because the focus of today's discussion has been on influenza and the early use of oseltamivir. With that, I would say namaste, and also request you to salute others and say bye bye by saying namaste rather than a handshake, for all the obvious reasons which we discussed during the course of this discussion. Thank you. It's over to you, Dr. Prashant.
Thank you, sir. Thank you. Thanks, Dr. Anil. Thanks, Dr. Sanjay. Thank you, sir, for your insights into flu, oseltamivir, and those case studies. I'm sure the audience has benefited. Thanks all the doctors who took time from their schedule and attended this. Thank you, marketing and sales team for Hitro for coordinating, and thanks Bhuvan for IT support. Thank you, sir.
Yeah,
Wish you a
thank
very good evening, and you can log off, sir.
Thank you, sir.
Thank you.
you.
Thank you so much.
Thank
Bye
you.
bye.
Thank you.
Bye,
Bye
sir.
bye.